Brothers and sisters in Islam, Assalamu alaikum. I'd like to begin my talk again with a request for a loud salawat ala Muhammad wa ali Muhammad. Right, so I'm first of all very grateful for the opportunity afforded to me by the organizing committee of Masumeen Center, and specifically Sheikh Jaffer, who graciously extended the invitation to me to come and speak to the community here on a couple of topics which we thought were relevant and helpful to the community, both in terms of a general sense, focusing on heart disease and risk factors, as well as Ramadan and the preparations for the holy month that all of us have to undergo, specifically people with medical conditions. Very recently, I actually gave part of this talk at the annual retreat hosted by Masumeen and Jaffer Center. I see a couple of survivors of the weekend here, so those of you who've seen part of the talk, please bear with me. The second part of the talk will be focusing on Ramadan. So I guess I have about 40 minutes, and I'll try to keep to the time. And if there are questions, please approach me afterward. If I'm running out of time, we can certainly have a discussion. So I would like to focus a little bit on why cardiac diseases are important, discuss a little bit about Islamic perspectives on diet and disease prevention, discuss a little bit about what the warning symptoms might be in terms of angina and heart attack, what you can do about it in terms of prevention, speak a little bit about the most common tests and treatment options we have available for heart disease. And then the second part of the talk will focus specifically on Ramadan and what we believe to be the biological as well as the spiritual benefits of fasting in the holy month. I'll talk a little bit about medical conditions and how they might impact upon one's ability to fast. Talk a little bit about dietary tips for Ramadan. And then speak just in a very practical sense about what sorts of things you might want to consider for this particular time where the fasts are the longest that they ever will be in our part of North America. So I always like to start my talks in the hospital setting with a case. So I couldn't resist but to create a case just for you. So this is a 42-year-old guy. He's fairly sedentary, he doesn't really exercise, he's mildly overweight, and he was last seen a week ago at this program where he looked fine. He's been ignoring recent onset of burning discomfort, which to him is just acidity. He hasn't even told his wife. He's under pressure, like most of us who have a job, to meet certain deadlines at work. And this past weekend, he did some heavy lifting in the garage because his wife was telling him that he hasn't done this for the last 3 months and he better get on with it. So he's under pressure. And of course, he hasn't seen his family doctor in years, and he couldn't tell you what his last blood pressure was or what his cholesterol numbers might be. Is this person at risk for heart attack? Sounds like it, right? Does it sound unfamiliar of a scenario to any of you? Unfortunately not. Is his body ready for Ramadan? Maybe not, right? So that's the second part of the talk. So what's the scope of the heart disease issue? Well, I think many of us in this room would know somebody who's had heart disease directly, been touched by it, who's had treatment for it. We know that cardiovascular disease accounts for close to a third of all deaths in Canada. So it's really a huge player. And it costs our healthcare system a lot of money, right? And it's the leading cause, not only of one of the leading causes of death, but also the leading cause of hospitalization. And when you have untreated heart attacks, you then lead to a lot of subsequent problems that lead patients back into hospital for complications related to the heart attack. And one of those complications is congestive heart failure, which we know is something that's increasing in frequency as time goes on. Now, the risk factors for heart disease, most of you would be able to recite these on your own. We'll talk a little bit briefly about these. Diabetes is a very, very important risk factor, and the reason why we talk about it so much is that although it's only 5% of the Canadian population, that's a lot of people, right? And diabetes is one of the most important risk factors for cardiovascular disease. One of the other aspects about diabetes that's important is that when you've had diabetes for a long time, you often don't have the same kinds of symptoms as a non-diabetic person might have if they're starting to develop heart disease. So in other words, diabetic people often have silent heart disease or silent heart attacks. And a thing that goes along with that is smoking. Now, thankfully, in the 60s to 80s, there was a declining prevalence of smoking. But lately, unfortunately, we're seeing a little bit of a rise in smoking again amongst the teenagers and the people in their 20s. Hypertension is also another super common problem. And the issue with hypertension is that most people who have it don't know that they have it because it's, again, a pretty silent thing. You usually don't feel your blood pressure unless it's really, really uncontrolled. And only about 15% of people who are on treatment actually have a blood pressure that's really where it needs to be most of the time. Cholesterol issues, well, we can go on and on about that. It affects over 30% of Canadian people, right? One way of looking at cholesterol is that it's actually good for you. It clogs your veins so you don't bleed as much when you get a cut. Obesity is another factor that we got to talk about when we're talking about risk factors. And a lot of times, these risk factors are not things that are disconnected from each other. And one of the things that links most of the risk factors together with each other is obesity. So when you tend to be overweight, you also tend to have cholesterol that's not quite right. You also tend to have a blood sugar that tends to be a little higher than normal. And your blood pressure tends to be a bit higher than normal. And when you have all of those things mixed together in someone who's a little bit overweight and who has all these risk factors there, we call that the metabolic syndrome. So it's really, really common to see that. And when people have it, most of them don't even know they have it, but they're walking around with a certain degree of cardiac risk. And one of the things that we're seeing nowadays more and more in both Canada as well as in the United States, maybe more than Canada, is the prevalence of childhood obesity. Right? And this is really a big, big problem. I think most of you are aware that children are a little bit less active than they used to be. Right? They spend a lot more time on their computers or their tablets, or because of changes in society, we're perhaps a little bit less willing to let them out of our sight and go play without any interference from us. We like to keep a closer tab on what the kids are doing and keep them closer to home. So unfortunately, all of these factors together, social media and technology and the busyness of this world, have led children to be less active than they used to be. And this is really the root of the future problem, which is that if we're seeing a lot more obese children now, you can bet that in 10 or 20 years, we're going to have an even larger problem or epidemic of these cardiovascular diseases. And in a Canadian context where our system is public, you can imagine what the impact is going to be on us as Canadian taxpayers to just deal with treating these problems. Just as a little bit of a schematic to illustrate that not only is obesity a problem in kids, but it's also become an increasing problem in adults as well as time has gone on. So what does the Qur'an say about nutrition? Well, we know that it speaks a lot about certain types of foods. There are many ayat in the Qur'an that speak about foods, and I'm not going to be able to really delve deeply into the science behind some of these discoveries that we've made, but suffice it to say that almost every food or nutritious material that's been described in the Qur'an has been proven by science to have very, very unique and beneficial properties. Some of these properties are anti-cancer properties. Some of these are blood pressure lowering properties. Some of these things are heart attack lowering effects. wonderful, wonderful effects that certain foods have been shown to have, and they're described in the Qur'an. So specifically, he talks about milk, talks about fish. We're now learning that fish have omega-3 and omega-6 fatty acids, which clearly the Qur'an has already spoken of, telling us that that's very healthy food. There's also a lot of mention about fruits and vegetables, but specifically certain kinds of fruits and vegetables. So, Allah's gone to the extent of mentioning that dates are of particular value, olives, pomegranates, and different fruit. And he makes a point to say that you should eat these fruit when they're in their season, perhaps because there's more added value to having a fruit when it's been freshly obtained. There's also an emphasis on vegetarian food, which is something that sometimes we don't do a good job of in terms of our own diet. But in the Qur'an, it clearly praises the value of a vegetarian food: corn, olives, dates, grapes, and other fruit. These are all very, very beneficial foods that have antioxidant properties, anti-cancer properties, and very beneficial effects on the cholesterol profile and the blood pressure. Again, we talked about milk. There's also specific mention of honey. Honey is actually described specifically as a substance that has a cure for illnesses. We're all aware of the various versions of the ahadith that are, some of them are attributed to our Holy Prophet, sallallahu alaihi wasallam. Where it's well spoken of that when you have to eat, if you have to eat, then you should restrict your eating to about 1/3 of the space in your stomach. It's actually mentioned that it's not appropriate for a human being to fill his stomach to his capacity. And it's really recommended that if you're going to eat, have about 1/3 of the space of your stomach for food, 1/3 for liquid, and keep 1/3 empty. That simple recommendation, it sounds so simple, but if we actually were to implement that regularly, almost 100% of the time for our major meals, and if we could apply that in a societal context and make everybody do it, I bet you we would see a dramatic reduction in many of these preventable cardiovascular diseases that we're all having to contend with. Another authentic hadith that I've shown there is that the concept being that whatever food you have, eat less of it. So although specifically you may divide your food into 2 and 2 into 4, the spirit of the second hadith there is just to simply give you the sense, the emphasis that you should really try to do with a little bit less food on your plate. What are the typical symptoms of a heart attack? Well, most people would describe it as a chest discomfort in the middle of your chest. Sometimes it's not in your chest, sometimes it's up in your neck, sometimes it's not even there, it's in your shoulders, or sometimes it's just between the shoulder blades and not at all in your chest. Most people, in fact, don't even describe it as a pain. They'll describe it as a pressure or a burning, or somebody's sitting on their chest. These are the kinds of things that people usually describe. Some people actually describe it as a burning that's not in their chest at all, but it's further down, in their stomach area. And because of that location of the symptom, some people delay the recognition that this problem that they're having is actually a heart-related problem, and they think that it's acidity, just like our fictitious person that we presented earlier, who was having symptoms mainly in their stomach area, and they thought that it was just a bad case of acid. But generally speaking, when you have these symptoms that come and go, and they're related to a blockage in one of your heart's arteries, we call that symptom something special. We call it angina. So angina is that symptom that you get when your heart's not getting enough blood flow. And like I said, there's some variability to what angina is, but for most people, the classic description is that central chest pressure or burning that comes on with activity or stress, and it gets better with rest, or gets better with nitroglycerin. So those are the features of angina. If you have that kind of predictable, repetitive symptom, then it sounds a lot like it could be angina. Sometimes when you have angina, when it's really, really bad, you might actually also get symptoms of shortness of breath, like you can't breathe. And if it's really, really bad, you might even get nauseated. If you're actually having a heart attack, which is further on down the sort of the spectrum, you might actually start to get sweaty and clammy and get really, really anxious as well. Well, what are the things that we can do in terms of preventions? We already know what the main risk factors are: high blood pressure, cholesterol, diabetes, etc. What we're sort of seeing here in this little table is that when you do these little basic things, you can actually see significant reductions in things like your blood pressure. So just by losing a little bit of weight, watching your salt intake, being a little bit more physically active, each of those things can actually lower your blood pressure, both the top number and the bottom number, by a significant amount. So if you were able to do 2 or 3 of these things, then you could definitely perhaps take away the need for using a medication for your blood pressure if you could do it with these sorts of things. What about cholesterol? Well, a lot of the things that help make your blood pressure get better also make your cholesterol get better. So again, getting down in terms of getting towards an ideal weight is really, really important. Getting a little bit more active and exercising regularly. So even if you don't lose any weight, but you're exercising regularly, you go to the gym 3 times a week and you hit the cardio and you're really breaking up a sweat, but you're not happening to lose any weight, you're still getting a lot of benefit from that from a cardiac standpoint. You're really reducing your risk by about 20%. Now we know that, at least in Canada, we have these guidelines for what sort of measurements you can sort of do to find out whether you're at the right target. For men, you want to measure your waist, and your waist should be below 102 centimeters, and for women, 88 centimeters. Okay? They advise that you should cut your fat intake down to no more than a third of your total calorie intake. And it's not that fats are bad. I mean, there's a lot of fads that come and go in terms of talking about fat. You guys all know that there were times where Baicel margarine or things like that were really fashionable and felt to be really, really heart healthy. We now know that that's probably not true. There was a time when butter was felt to be just absolutely horrible and we should all stay away from butter. Now we really don't believe that so much anymore. We used to think that eggs were terrible and we should never touch eggs. Now we also think that that's not so much true. What we do seem to know is that not all fats are bad. In fact, some fats are really, really good fats. And the things that we know is that the good fats come from things like nuts, from seeds, and from fish, for example, right? The kinds of fats that are not good are the things that are called trans fats. And you can clearly see that in most labels when you go to the store. Just check the labels and see what kind of fats are described in there. So there are different kinds of cholesterol-lowering drugs. I'll only mention them a little bit just because a lot of people are on them. And there are some misconceptions about what these drugs do and what the side effects might be of these drugs. So there are generally 4 types of cholesterol-lowering medications. The most common kind that most people will be on is what's called a statin medication over here. So things like Lipitor or Crestor, those are very common statin drugs. Okay? And the reason why there's so many of these being prescribed out there is because the evidence shows that if you've got heart disease or major risk factors for heart disease, being on a statin drug lowers your risk for heart attack or stroke by close to 30% compared to if you weren't taking the medication. And when you look at all of the evidence of these different kinds of medications, the statins really have the biggest benefit proven to reduce the chance of dying from heart disease. So they're pretty important. Now,
what about triglycerides?
Triglycerides are also a risk factor. And it's not as much a risk factor as the LDL cholesterol being high or the HDL cholesterol being low, but high triglycerides are a risk factor in and of itself as well. It's a good question. And statins don't have a huge effect on lowering triglycerides, but some do. But if you have if your major problem is that your triglycerides are very, very high, then you can target that with a different class of drug, which are called fibrates or fibric acid medications. So what about the common tests? I'll just spend a minute on that. So everybody knows about the test called the ECG. Well, what does the ECG actually tell you? The ECG could tell you if you're having a heart attack right now, okay? Because there are changes that show up on the ECG that tell the person reading it that this person looks like they're having a heart attack right now. It'll also tell you whether or not you had a heart attack in the past, because once you've had a major heart attack, the ECG will always show this abnormality. It'll never go away, and that will prove that you had a heart attack in the past. It'll also tell you that your heart might be a bit enlarged, and it might also tell you that your heart electrical conduction system, in other words, the heart rate, is not normal. What it won't tell you is whether or not you have any plaques or blockages in your arteries right now. It just cannot tell you that. So lots of people say, oh, the ECG was fine. How come he had a heart attack the next day? That's because the ECG doesn't predict or doesn't tell you what's going on inside the arteries when it's not causing a heart attack. One of the common most tests that we do to help diagnose whether or not there's heart disease or a risk for it is a simple stress test. Some people here might have even had one. It's a pretty simple concept where you're exercising under supervision, you're hooked up to an ECG and a blood pressure monitor, and what we basically look for is how the ECG changes when you're exercising and pushing yourself hard, how your symptoms might change when you're pushing yourself hard, and whether or not the two things correlate with each other. Okay? So for example, if somebody's complaining of chest pains and you have this test done and you exercise them and midway through the test they're getting a lot of chest pain and at the same time the ECG starts to show something abnormal, well, there you have a very, very strong prediction that there could be a blockage in the arteries. Okay? Now I'm simplifying it down, but that basically is the way a stress test is when the stress test becomes very useful. Now, where the stress test is not that useful is when it's completely normal, yet you still have a lot of concern. So let's say you've got somebody like that person that we described in the case who's got all these risk factors and they're complaining of the very typical angina that we talked about, and we did a treadmill stress test on them, but the test came back normal. In that situation, the stress test doesn't really fully rule out that there is not a heart problem going on. And so when you have that strong level of suspicion about a patient, you got to go a little bit further. One of the ways in which you can go further is by doing a fancier stress test, which is called a nuclear scan, where they do the same thing that you just did with the exercise treadmill, but they inject you with a radioactive tracer that basically shows how the blood flows in different parts of the heart, and that can add a little bit more accuracy to the overall prediction of whether or not there's a blockage. The problems or the issues with this test is that it gives you a hefty amount of radiation to your body when you take the test. It costs the system a lot of money, and it's still not 100% accurate. Another common test some people might have experienced is what's called a CT coronary angiogram. This is also a pretty neat technology where you're basically getting a CAT scan with lots and lots of slices of your chest taken with X-ray, and then a software reconstructs your heart and takes pictures of or reconstructs the arteries and can tell you a lot about what's going on with the arteries, including whether or not there's any calcium that's built up inside the arteries. And you might have heard about people getting calcium scores done. Well, what that is basically a CT scan done to quickly screen to see whether or not there's any calcium showing up in your heart's arteries. It's not normal to have any calcium in your arteries. So if you have a calcium score of, let's say, 1,000, that's really, really high. And that could indicate that there's potentially a narrowing in your arteries. Having a high calcium score doesn't necessarily mean that you've got a tight blockage, but the higher your calcium score, the higher the likelihood that there happens to be a tight narrowing somewhere within your arteries. Now, ultimately, once you've had some of these tests done, you might actually progress to doing an angiogram, which is a test where we actually put a catheter inside and take a bunch of pictures of the heart's arteries directly with X-ray. And that's what's going on this side of the screen. This is an example of how we use an angiogram. A lot of times we use angiograms to treat people who are having a heart attack. And thankfully here in the GTA, as well as in Kitchener, where I am at, we have this system available for 24 hours a day, 7 days a week, where if you're coming in with a heart attack to the hospital, they promptly diagnose it using the ECG, and they'll activate the team, whether it's 2 p.m. or 2 a.m., and the team will come in within half an hour to do this test, to look at your heart's arteries, figure out where the blockage is, and then open it up. So that's exactly what's happening here. Over here on the left side, this is a full blockage of one of the major arteries of the heart, feeding the front of the heart. It's blocked right here. This is a stent being put in the artery. And then over here, after we've opened the artery, you can see all this flow down the front of the heart. So that's a huge heart attack that this person was having, but because the artery was opened up in a reasonable time frame, a lot of damage was prevented. A lot of times when we do these heart attack treatments, we actually put a little catheter down and suck out whatever might have been blocking the artery. That's exactly what there's a picture of here. It comes out in this syringe full of blood. We push it through a little filter, and then you see what comes out. So over here, there's this big red thing, which is basically a clot that happened to be blocking the person's artery. So heart disease is really common. It affects our community a lot, and we need to be more aware of it. We got to pay attention to our risk factors, look inside ourselves, and see what kinds of things we can do to make our situations better. And if you have heart disease, especially leading into Ramadan, you really want to consult with your physician and figure out whether or not there's any specific things that you may need to do to prepare your body for the month of fasting if you want to fast. So in terms of preparing for Ramadan, hopefully we're all fasting because we want to improve our taqwa and our spiritual well-being. Many Muslims who have medical conditions want to fast but are sometimes hesitant to fast or are actually prevented from fasting by their physicians or somebody else who tells them that it's not safe to fast, so you better not do it. So I just wanted to spend a few minutes talking a little bit about some of those issues. Well, we know who can't fast from our religious standpoint, from Ayatollah Sistani's website. You can clearly see that these are the 5 specific situations where Syed has told us quite clearly that these people in these situations need not be fasting. So clearly anybody who is of old age or who is in extreme hardship, anybody who has a medical condition where that condition causes excessive thirst or extreme hardship or suffering, women who are menstruating, women who are in the sort of advanced stage of pregnancy, which I guess would mean the 2nd trimester or beyond, and women who are breastfeeding. A question in the back? If you don't have a... I could...
You don't have food to break the fast.
Correct. Well, I mean, if you don't have food, you're really out of luck. It kind of goes against the principle of fasting, where you're prescribed to fast from a certain time to a certain time, and then the commandment for fasting, as I understand it, is not only to fast but also to break the fast. So if you can't fulfill that part of the equation, then that's not fasting in the spirit and the sense that I believe he wanted it to be. Now, what are some examples of challenging medical conditions that are pretty common? So diabetes, for sure. We talked about it a lot. You probably know that there are 2 kinds of diabetes, type 1 and type 2. Type 2 diabetes is the vast majority of diabetic people. About 80% of diabetics, 90% of diabetics are type 2, and type 1 is about 10 to 20%. Type 1 diabetes is very, very different from type 2 diabetes. Type 1 diabetes is the kind where your pancreas just doesn't make any or enough insulin to meet the needs of the body. And you need insulin to process sugar. So in type 1 diabetics, there is really no insulin unless you actually take it yourself in the form of a medication. In type 2 diabetics, it's not that there's no insulin around in their bloodstream. In fact, if you measure, they have more insulin than normal people. But the problem with them is that their bodies aren't as sensitive to insulin, so you need a lot more of it to achieve the same thing, or you need to be on a bunch of medications that make your body more sensitive to insulin. And so because of those two differences in conditions, I thought that was really important for you to be aware of that. Type 2 diabetics in general are people that could go ahead and fast, provided that there's certain conditions met. Type 1 diabetic people, it's really, really difficult to fast, because if you go more than 12 hours without any insulin, you run the risk of developing a very severe condition called ketoacidosis that could put you in hospital and make you very, very sick. So type 1 diabetics, it's a very, very big challenge in order to fast. Certain people with severe heart conditions or lung diseases, people who sometimes get very severe uncontrollable migraines, for example, when they fast, it can be so bad that it can prevent their functioning day to day. They sometimes need to be locked in a room, in a dark room, because of their migraine. They just can't function. So that's clearly an example where if that's really what's happening to you, that's causing you a lot of hardship and undue suffering that prevents your day-to-day normal functioning, then that would be a condition where you would be exempt from fasting. The difference between fasting and just not eating is something that I think we all understand quite clearly, which is that there's a huge spiritual component to what we're doing here. And it's not just the deprivation of food and drink, but that feeling that you're adhering to something higher than yourself, you're fulfilling the commands or the obligations that God has wanted us to fulfill, and that, if we truly believe in that, then we're basically giving ourselves a deeper sense of fulfillment by doing this. And of course, during the holy month, most of us, or many of us, spend a lot of time in extra prayer than we normally might. And because of that, there are these additive benefits to the experience of fasting. One of the common beliefs I've sort of encountered over time is that I'm diabetic. If I fast, my sugars will go down, so I can't fast. Is that true? Anybody think that's true?
As you said, depend on type 1 or type 2.
Yeah, let's say you're a type 2 diabetic. Yeah, so in fact, the sugar might actually go up, right? So in type 2 diabetic people, when they're under a lot of stress, their sugars actually go higher than normal. But in fact, so it's false. In fact, what we see in, let's say, non-diabetic people, just anybody who's fasting, that their sugar levels in their bloodstream in the month of Ramadan during the fasting sort of goes a little bit down. Okay, not a lot down, just a little bit down. And when the sugar levels go a little bit down, then the pancreas, which makes insulin, also takes a bit of a break. It doesn't have to do much work at that time. And as a result of the insulin levels going down, you have the opposite hormone, which is called glucagon, goes up. And we know that glucagon and this other hormone called growth hormone, when they go up in the fasting state, that clearly produces a state within your body which is very, very stable, right? There's not a lot of variation going on. And as I'll kind of, hopefully if I get to it in time, I'll be able to show that some research is showing that glucagon and growth hormone, these hormones actually are hormones that protect against the development of certain diseases. Now, in terms of cholesterol as well, during the month of Ramadan, there is usually a slight reduction in total cholesterol and triglycerides in the first few days. But as our bodies adapt to the changing sort of schedule, they kind of go back to where they were before. But of course, a lot of that depends on what we do and what we eat, right? A lot of you may have heard that there's a lot of Western scientific literature talking about the potential health benefits of fasting. Scientists are now coming on to this discovery that they first started off looking at this in mice, And now there have been some human studies looking at both starving mice as well as fasting mice, showing that they lived longer compared to well-fed or overfed mice. And now there are some human studies that suggest that you might actually prevent cancer or certainly reduce the recurrence of cancer if you've already had it. This was an important study that was just published last year in a very reputed journal, where it looked at 2,400 women who had already had breast cancer. And they studied them from anywhere from 4 to 11 years later. And it looked at a couple of things. It looked at, it randomized these women to 2 different kinds of diets. One, or they didn't randomize them, but they looked at these people in terms of their eating and sleeping patterns, and they broke them into 2 groups. One group were people who had basically greater than 13 hours of a fasting period between their supper meal and their morning meal, so that this long period where they didn't eat or drink anything. And then there were people who had less than that. So they used that 13-hour cutoff, and they showed that women, breast cancer survivors who had that greater than 13-hour period of not eating or drinking actually had much less, 36% lower recurrence of breast cancer in follow-up than the people who had less than the 13 hours. So that was a pretty interesting finding. It generated a lot of discussion. People started talking about this a lot more. There's also this study that was just published this year. And this is very interesting because this was only a 6-month study where it took 100 healthy people and it put 50 of them into this sort of fasting-like diet and 50 of them in a normal diet, and they observed them. The people who were put into the fasting-like diet, they were only asked to do that for 5 days in a month, for 3 months in a row. And then at the 3-month mark, the 2 groups of 50 people swapped, and they did the opposite thing. So as a result of that, they kind of got about 70, 75 people who had done this sort of fasting exercise for only 5 days in a month for 3 months in a row. And what they were able to show was that there were huge reductions in these people who had just done this 5 days in a month. They had huge reductions in these hormones that we know are predictive of bad things happening to you, right? So when people, like for example, come in with a heart attack, you can measure certain hormones that are called stress hormones, like CRP and things like that. And we know that when these enzymes or hormones are really high in the blood, that it predicts that you're going to have a higher risk of major health problems down the road. So what they showed in these people is that even this short-term exercise of kind of fasting reduced levels of growth of hormone IGF-1. It reduced your body mass index. It dropped your sugar levels. It dropped your triglycerides. It made that C-reactive protein go down. And all of these things we know are markers that indicate disease. And so while this doesn't prove that fasting reduces diseases, it certainly lends a lot of support to that potential theory. And so the question I have is, if this is actually true, then imagine what an annual practice of doing this for 30 days a year for most of your life might do for you. It's pretty interesting. So obviously, in a general sense, if you're going to be fasting and you have concerns, talk to your physician. One of the options, especially now when the fasting is getting kind of long, you might actually want to start preparing your body a little bit before the start of Ramadan. You might start fasting in Shabaan. You might not perhaps do the whole official fast, but you might even do sort of mini fasting. So if you want to prepare your body for it, you could just sort of do half days for a few days. It won't count for anything, of course, but at least it's preparing your body medically towards longer and longer and longer periods of fasting. If you're on blood pressure medications, there are a lot of drugs now that can be just given once a day, and most of us are pretty receptive to sort of making them convenient for patients to make them all be given at nighttime or bedtime. And so that would work pretty well for most fasting people, where you would have your iftar, and then an hour or two later, just before you go to bed, you could have your blood pressure or cholesterol medications, and that's that, right? So in what we know in the couple of minutes that I guess about 5 minutes that I have, just to talk about diabetes in specific, we actually see that diabetes control gets better in Ramadan. I'm not talking about sort of the really extreme diabetic people who have uncontrolled diabetes, but most average diabetic people, type 2 diabetics, when they fast, their diabetes actually doesn't pose a problem to them at all in the month. They just maybe have to adjust the timings of some of their medications, but their sugars actually kind of go down. They may notice that they have to use less medication dose than they would if they weren't fasting, and things just generally work out pretty good. Not only does the sugar kind of get better, but their blood pressures go down a little bit, and they might actually end up losing a little bit of weight. Specifically, if you're diabetic, there's a drug called metformin. If you're on it, usually we like people to stop that drug about a week before Ramadan because it can potentially affect your kidneys. There are a bunch of specific diabetes drugs that I just sort of listed here. Some diabetes drugs are not as good as others or not as safe as others when you're diabetic and you're fasting. So you might want to have a conversation about switching some of them. If you have questions about that, I can try to answer that after. In terms of those people who are type 2 diabetics who are on insulin, there are some general guidelines as to what to do about that. Generally, it's a little bit of a play it by ear, but you're trying to predict what will happen when your diet timings change. Most of us would recommend that you drop your insulin dose by about 20% or so. And if you're on these what are called mixed insulins, which are short and long acting, kind of get rid of those and just go to the long-acting insulin and then just go to a slightly lower dose of it. And if you're monitoring your sugars, you would obviously do it at suhoor and iftar times and then kind of make a decision as to whether or not you need any short-acting insulin on top of that. Type 1 diabetics, I already sort of mentioned, it's really, really difficult for them to fast when the fasts are this long as they are now. In the winter months, it's not so much of an issue, like your fasts are only 10 hours long. Type 1 diabetic people can usually do it. But again, it's a situation where you really want to have a discussion with your specialist before you do that. A lot of people sort of wonder, what's the ideal diet in Ramadan? Well, there's a lot of information out there. I posted a couple of links here, and I'm happy to circulate that later on. But the National Health Service in the UK has actually published a 30-page document that is really, really well-written and helpful, giving lots of practical advice to people in terms of deciding what sort of preferred types of foods there are, how to prepare your foods, things like that. So I'm happy to share the details of that, right? But in general, when you're talking about suhoor, you number one, you want to have a suhoor, okay? So some people actually, I know, don't even have that. They sort of get up in the morning, they'll say they'll have a glass of water, they'll recite their brief prayer and their fajr, and then that's it. So they'll go basically 24 hours with one meal. Now that's doable, but it's an unnecessary strain, right? And from a health standpoint, that I don't think confers any benefit to you by doing that. And in fact, it's healthier and safer for you if you actually get up and have a wholesome suhoor, which should sort of have foods that are of sort of slow release. So bran, oatmeal, those are very, very helpful. They have this nice sort of profile of slowly releasing sugar over hours. And then, of course, cereals and fruits, those are all obviously very, very good in the morning. Iftar time, we'll spend a little bit of minute talking about iftar, but I'm a big fan of people breaking it up into pieces and starting as early as you can. As soon as, obviously, it's time to break the fast, then really get on it. Get on it with not just water, but have about 4 or 5 dates. Drink a good volume of juice or electrolyte sort of solution. Get that going because your body is converting from a fasting state to a state where it's now going to be receptive to sugars entering the bloodstream. And so the liver needs a little bit of time to make that metabolic change. And when that happens, sometimes your brain feels a little bit weird as you're converting from breaking down fats to, again, utilizing sugars. So I know that sometimes when we come to the mosque, we may break our fast with a date, and then we'll wait another sort of 20, 30 minutes before we actually finish all of our prayers, and then we'll go to the dining hall and then have our gigantic feast. So that's kind of not what I would recommend. I'll just sort of skip this. It'll be in the document that you can get later. But we have to recognize that our fasts, like right now, are extraordinarily long, 16 hours or more. And we need to think about practical ways in which we can make that sustainable, especially in our busy, crazy lives that people lead. What are some of the smart things to do? Well, I mentioned already that you want to start preparing even before the month of Ramadan. It's not like you can sort of go till the night before Ramadan doing all the bad things that you might typically do, and then the next morning at 4 in the morning, you're ready to go. No, it's not the best way to do that. So perhaps you might want to start a week or two before, consider exercising, getting in shape, losing weight. And I mentioned the concept of perhaps mini fasting if you're concerned about your ability to do the whole 16 hours. Just do a little bit at a time, do a half day or whatnot. Talked about sahur. Go a little bit easy on yourself if you're fasting, then don't just kind of rush out to do your normal things. And then when you're breaking your fast, break it up slowly. So what I would personally recommend is consider that as soon as you break your fast, have some fluid, have some electrolytes, have some dates, then pray your maghrib, then go back, have a little bit more to eat, then do your isha, and then continue to eat. So I'm going to stop right there. I think I've just reached maghrib time. I'm happy to answer any questions that you might have later on. Thank you very much for your attention.